Dr. Scott Brodie is a professor of clinical ophthalmology and attending ophthalmologist at Columbia University Arkansas Eye Institute. He is an internationally known clinician, scientist, and a leader in the use of electrophysiologic techniques for diagnosing of visual impairment in children and adults. Dr. Brodie is a graduate of the combined MD PhD program at the Rockefeller University in New York. He completed his PhD in retinal physiology in the laboratory of Nobel laureate H.K. Artline under the supervision of Dr. Floyd Ratliff and Professor Bruce Knight. He completed residency training in ophthalmology at the New York Hospital and subsequently received fellowship training in medical retinal disorders and clinical electrophysiology of vision at New York University as a John Kluge Fellow of the Retinitis Pigmentosa Foundation. His many accolades include Senior Achievement Award of the American Academy of Ophthalmology, as well as the Academy Secretariat Award of Education. His research centers on improving methodologies for electrophysiologic testing and description of novel findings in patients with inherited and metabolic retinal disorder. He has been a key member of the team that have introduced important new therapies, including enzyme replacement therapy for Fabry disease and intra-arterial chemotherapy. He has published extensively on electrophysiology and retinal disorder. He has a particular interest in clinical optics and has served as chair of the editorial committee of the American Academy of Ophthalmology Basic and Clinical Science volume on clinical optics. In his spare time, he enjoys reading mathematics and playing the oboe in local orchestra and chamber groups. It is our privilege to welcome Dr. Brodie as he presents two lectures, Plaquenil Update and Discrepant DNA.
Okay, thank you very much, Ella, for that lovely introduction. I want to thank Ella and Dr. Levin for their extraordinarily warm hospitality here in Rochester, notwithstanding the fine weather. I have two talks here. The first one begins with a quote, perhaps not as uplifting as the one we saw a moment ago. So I just saw a show of hands. We hear a lot about plaquenil toxicity. We worry a lot about it, but how many have actually seen a case? Plaquenil toxicity? Not so many. It's rare. For all the fuss, it's pretty uncommon. So let's begin with a bona fide case. There's a 57-year-old woman with a diagnosis of rheumatoid arthritis and lupus. She'd been taking Plaquenil at 400 milligrams a day for 20 years, a total cumulative dose of approximately 3,000 grams. And she'd been conscientiously monitored with annual dilated fundus exams and Humphrey visual fields by her local ophthalmologist. In those days, it was thought red test targets might be more sensitive. But not quite 2 years ago, her retinal specialist noted that the acuity had dropped a line. The macular changes in appearance were very subtle. This is a quote from his note. Tiny depigmented spot in the foveal center, a few tiny alterations in RPE supratemporal to foveal center, tiny trace foveal depigmentation in foveal center with 6 to 8 tiny dots of RPE. No bullseye maculopathy or other fundus abnormality, normal visual fields, not consistent with clinical findings of plaquenil toxicity. Well, 20 months later, the acuity was now down to 20/30, 20/40. There was a visible maculopathy, bullseye appearance, I'll show you in a moment. There were dense central depressions to red targets on the 10-2 visual fields, and OCT irregularities with patchy frank dropout of the RPE line in the posterior poles in both eyes. These were the scotomas on 10-2 testing. These were the fundus photographs. Okay, do we have to dim the lights, or can you see the bullseye pattern?
I can see it. Yeah.
I don't have the pictures from 2 years ago, but I'll have to take the guy's word for it that he was not alarmed. Here's the autofluorescence, certainly a bullseye maculopathy now. Now here are the OCTs, and as you can see, there are sort of paracentral gutters structures, and the subfoveal tissue has been reduced to what I like to refer to as photoreceptor debris. So it can be debilitating, and it can progress remarkably rapidly after many, many years of quiescence. Now, I don't know how many of you had a chance to see this, but recently the Ophthalmology Journal circulated preprints of this update in the Academy Guidelines for Screening, which I believe will be published this coming June. And so I'd like to share some excerpts from that. I agree with almost all of it. The key points are, first of all, that hydroxychloroquine or plaquenil toxicity does not evolve steadily over time. The retina frequently remains clinically normal for many years on proper dosage, but there's an unpredictable point at which signs of toxicity may appear, and the progression after that may be quite rapid. It's reported that patients of either European or East Asian heritage most often have a parafoveal or pericentral pattern of disease. Two things, but anyway, but not exclusively. You should look for both patterns of visual field loss. I've been a little troubled by this emphasis in the last few years about Asian patients having a greater likelihood of more peripheral disease. That comes from a single paper out of California, which studied about 100 plaquenil patients from the local VA hospital, of which about 25 or 30 were of Asian heritage, which seems to me a pretty small sample on which to base such sweeping conclusions. But it has caught hold in the literature, and we're not going to get it out. So the bottom line perhaps is better put that we should look for more peripheral field loss as well as central field loss in all of our patients. The safe harbor dosing recommendations have not changed recently. No more than 5 milligrams per kilogram per day of real body weight. You don't have to make a difference between lean and obese weight, and never more than 400 milligrams a day. Additional risk factors are renal disease, concurrent tamoxifen usage, and perhaps initiation of treatment at. The AAO's recommendation is that primary screening be primarily OCT and wide field fundus autofluorescence imaging. I'm not as confident as they are that the earliest abnormalities will appear in those two modalities. But in any case, at the least suspicion, you should proceed with visual fields and, if available, or that there is more suspicion, with multifocal ERGs. I'll give you some examples of those in a few minutes. There's newly available a modified Humphrey Visual Field Protocol called 24-2C. And the idea, I'll show you examples in a moment. The idea is that they've added not the entire 10-2 array in the center of the 24-2 array, but they've added 10 points in addition. And they find that the sensitivity in both Asian and European patients seems to be significantly improved. If you don't already have that on your perimeters, it shouldn't be difficult to arrange to get it. In addition, I'd mentioned that though rely more on age than cumulative exposure, and those of course are highly correlated, I like to think of it in both ways, that the safe harbor is no more than 800 to 1,000 grams of plaquenil over a lifetime, which is about 6 years of treatment at 400 milligrams a day. Below that, I'll show you data, the incidence of toxicity is just 1% or 2%. Above that, it goes up 1% or 2% a year. After cessation of treatment, for whatever reason, the vision is usually stable. If patients have lost some vision, they usually keep what they have, but there are no guarantees. The patients may further deteriorate even after they stop, and there are a few lucky patients, mostly those who have had relatively low exposure to the drug, who may partially recover after they discontinue treatment. So it's worth continuing to follow them, at least for a few years after they stop. Finally, I'd mention that the toxicity may present years, or even in a few patients of mine, decades after they've discontinued treatment. So you're never completely safe if you've taken a significant amount of plaquenil. This is the stimulus for a multifocal ERG. The cartoon tries to illustrate the way the spots flicker on and off. That's according to a complicated mathematical recipe, so that with careful fancy arithmetic after it's done, the signal from a single electrical contact with the eye can be processed in such a way as to yield a map of the responsiveness of each retinal sector corresponding to each of these hexagons. And that map is an important indicator of localized retinal function and has been proven to be a very sensitive indicator of plaquenil toxicity. Here's another example, you've seen one already today, of a normal multifocal ERG study. These are the averages of the concentric rings. Here's the response array in terms of the actual waveforms. This one corresponds to location of the blind spot. You see the response is a little smaller. And in this color contour plot, again, you see a little dimple there corresponding to the physiologic blind spot. Now here's an example of a patient showing how over the space of 4 years, the 10-2 visual field showed progression at a dosage of 8 milligrams per kilogram, which is a little high. It's been said, and I agree with it, that a single missed spot on a high-quality 24-2 study or 10-2 study is reason to be suspicious. I don't think you have to stop the drug right away, but at very least you should repeat the study and see if that's a reliable defect or not, and refer the patients for further evaluation, including, if it has not been done already, OCT and perhaps multifocal ERG if you have access to it. Here's that patient that I just showed you with progressive field loss. Again, the fundus looks pretty normal. There's this one little area of parafoveal outer retinal damage. There's a slight suggestion of hyperfluorescence in the autofluorescent image in the parafoveal region as well. Here's an example of a Chinese woman, the same woman, the 8 milligrams per kilogram per day. And you can see that the field loss in the 30-2 is more severe in the pericentral region than it is centrally. And here's her multifocal ERG showing this quadrantic pattern of loss roughly corresponding to the location of the field loss, as well as the area of outer retinal loss in the OCT. Again, not so much central or pericentral, but further peripherally. So we have to look in both places. These are examples. These are not the same patient, but these are examples from the AAO paper showing various stages of plaquenil toxicity. Here's a normal patient at the top with what we hope is a normal field. And here is a patient with a paracentral RPE defect and early field loss. Notice it's not always dramatic, it can be subtle. And here's a patient with more advanced loss, significant paracentral defects, more symmetrical. Scotoma. This is in the 10-2 region showing the typical parafoveal location of the field loss, a ring scotoma, if you will. And here's a patient with very advanced disease. These are the statistics from the AAO paper. On the left is the sort of Kaplan-Meier plot of the cumulative risk of toxicity as a function of daily dosage, stratified less than 4 milligrams per kilogram per day, 4 to 5, and finally greater than 5. That's a big difference over that rather small range. And again, before 5 years of treatment, there's essentially no toxicity. I may have seen one such case in 40 years. But as you get out to 10, the toxicity is minimal except for patients at a higher than recommended dose, and it just keeps creeping up after that. These are sort of the yearly risk of toxicity. Basically, the derivative of this curve is what's here. And again, you see that beyond 20 years and at high doses, the risks become quite high, 0.15 risk, that's 15% per year. Patients with that cumulative treatment and at that high dosage. This is the schematic of the 24-2C visual field protocol. All the spots from the traditional 24-2 are present. And in addition, they've shown that the 10-2 array in the triangles, they didn't include all of it in the 24-2C, but they've added these 10 additional points in blue circles. I don't quite know how they chose exactly those, but that's what's there. And here are examples, an example of how that extended array is useful. Here's a patient with early toxicity. You can see the sectoral hyperfluorescence and a little bit of breakdown of the RPE and outer retina. The traditional 24-2 field basically has one missed point, easy to dismiss if you're not being hypersensitive. But the 24-2C shows a more significant paracentral defect, which of course, but the point is that you don't need to do both of them. That combined pattern seems to be quite useful. And here are published data comparing it. For parafoveal lesions, that it's just as sensitive as a bona fide 10-2. And for pericentral lesions, it's actually more sensitive than the 30-2. And so that's what we're doing at Columbia these days and what I certainly recommend. Here's another patient of mine. Again, the field defects, if you're looking casually, look quite modest. If you look at the pattern or the total deviation, it perhaps is brought home a little bit more dramatically. This is a 10-2, so maybe that's the beginning of a paracentral ring, but it's hard to say. But her multifocal ERGs are absolutely classic. You can see there's the central depression, and we have these beautiful illustrations of the paracentral gutter of the loss of function in the paracentral region. But that's what we're aiming for. Now I just want to end with a few examples of these rare cases that illustrate these unusual patterns which do occur. This is an example of a patient whose visual defects progressed even after she stopped treatment. She was 71 years old. She had been taking the drug for over 10 years for rheumatoid arthritis. Her estimated cumulative drug exposure was 1,600 grams, so well above our safe harbor limit of 800 to 1,000. She had stopped 6 months before I saw her and complained of rapid deterioration of vision for less than a year, for 10 months. She was down to 20/30, 20/40, pressures were fine. And these were the 10-2 visual fields. And what I'm showing you here, the top ones are from June of 2017. And you see we have fairly dense ring scotomas here. But if you start comparing point by point at the fields from January of 2018, later, you can see that the scotomas are denser, that we're starting to fill in, where did my pointer go? Here inferiorly, we've started to fill in. This area down here is denser than it was there. So her fields have definitely deteriorated in barely half a year, even after she stopped treatment, with a fairly high degree of exposure. I'm not sure that I could see any appreciable changes in the fundus or the autofluorescence. The OCTs, it was again hard to say, but I think these areas of parafoveal deficiency are larger, and the area of central sparing is probably a little bit less clear. I would point out that there are a few little tiny cystoid defects, at least seen in the earlier OCTs. That is also a reported sign of plaquenil toxicity. You don't need to go running for other possible causes. That's consistent with this diagnosis. And here are her multifocal ERGs. But my general impression was that they got worse between 2017 and 2018 as well. Here's an example, also quite rare, of a patient who recovered after stopping plaquenil treatment. A 60-year-old physician. She had undifferentiated connective tissue disease and been treated only for 4 years. Her initial dosing was 400 milligrams a day. That's the upper limit of the safe harbor. And after 2 years, she went down to 200 milligrams 5 days a week, so much less. So her cumulative dose was only 450 grams, which I would not ordinarily think of as putting her at risk. But she actually complained of a ring scotoma. That's unusual. And the visual field defects were quite convincing. A fluorescein angiogram was not informative, but the plaquenil was discontinued and she was referred. So here she is with 20/20 central vision, normal pupils, and there are the paracentral rings, very classic. And here with the fundi, I thought they looked pretty much normal. One sometimes sees a duskiness of the maculas in plaquenil patients, and many retina specialists consider that too subtle to call as an abnormality, especially in older patients whose foveal reflexes tend to dull anyway, but that may be the first ophthalmoscopic sign. The autofluorescence was likewise essentially benign as far as I could tell. And here are the OCTs, and again, there's a little hint of a lucency there in the parafoveal region, maybe a little bit more there, not a frank defect, not a total collapse, but subtle stuff. And here are the multifocal ERGs. The central peaks survive, but the fall off from the central peaks is a little bit steeper than we would like to see. 2 years later, she came back, and the multifocal ERGs were arguably, but more convincing than that were the visual fields. You've seen these top two visual fields already, and here she is 2 years later, and the ring scotomas have started to break up. So it doesn't happen quickly. I've never seen anyone completely normalize after discontinuing plaquenil with toxicity, but they can at least get a little bit better. Finally, I have an example of delayed onset of toxicity. This was a 40-year-old African woman. who had been in the US for many years. She complained of decreased vision for about the past 9 or 10 years, so beginning at age 30. Her prior workup mentioned cystoid edema, an inconclusive uveitis workup, and she came in with Goldman visual fields with paracentral defects. 24-2 is at least a diffuse loss of sensitivity. The multifocal ERG showed central depressions, and these were workup elsewhere, those were mine. And the Gansfeld ERGs were normal. These were the Goldman fields with these paracentral defects. These are the color fundus photographs, and you see again, there's at least a suggestion of a beginning of a bullseye maculopathy and discoloration of the foveal regions. The OCTs showed very substantial central damage, as we've seen before, a few cases. Again, a ring of hyperfluorescence and a little bit of irregularity in the very center. I managed to get some additional history. She had taken, not Plaquenil, but chloroquine when she was a child in Madagascar as anti-malarial prophylaxis. Now, we hardly ever see chloroquine used in this country anymore, primarily because at an equitherapeutic dosage for its anti-inflammatory or anti-malarial properties, it's about 10 times more retinotoxic than Plaquenil. But you still see it once in a while, and so the safe harbor for chloroquine is about 100 to 300 grams rather than 1,000 grams for chloroquine. So she had taken about 300, what was the total? She had taken something like between 75 and 150 grams, which puts her in the potentially toxic range. But she stopped when she was 10. And she first started complaining of loss of vision when she was 30. So a 20-year interval in between. Now, this is an old paper showing best-corrected acuities in patients who had stopped taking chloroquine therapy. And in this paper, there were patients who had delays of at least 5 or 6 years before they reported losing vision. As far as I know, the toxicity of chloroquine and Plaquenil are qualitatively the same, just different dosing. And so this is rare, but not unheard of. So patients who have the appropriate findings and a longer history of Plaquenil usage probably have Plaquenil toxicity as well. Okay, any questions about Plaquenil?
They often talk about the UFO sign.
The flying saucer sign is sort of a lucency in the subfoveal region in the OCT. And in the paper which described it, they show the OCT, and next with the copy of the OCT with a silhouette of a caricature of a UFO next to it. And with that prompt, it's easy to see what they're talking about. But when I look at it in my own patients, I'm never quite certain. Many people have a certain degree of lucency of the subfoveal tissue in an OCT, and I'm not able to differentiate that confidently in my Plaquenil patients from everybody else. But if you see it, by all means, report it. Yeah.
Just have a comment. I thought that was a great presentation, especially that first case, where there's a description of those like very mild, subtle pigmentary changes. And just wanted to highlight, especially for the residents, if you see anything on the fundus with Plaquenil, like it's already too late. OCT is often going to pick everything up first. And so very low threshold, any history of Plaquenil, just get the OCT. Changes.
Yeah. I'd like to reiterate just what you said. The original guidelines for interpreting the multifocal ERG for Plaquenil toxicity were very conservative. They wanted to use 95% confidence limits and use a very suspect arithmetic procedure for processing the data. My feeling is that at the earliest sign of Plaquenil toxicity in any dimension, fundus appearance, autofluorescence, OCT, visual field, multifocal ERG, any of them, my advice to the patient is to stop, even if their vision is otherwise excellent. I'm practicing in the litigation capital of the planet, and my feeling is my job in that situation is to give the patient the option to stop before they lose vision. Once they've started to palpably lose vision, as Mark said, it's probably too late. And I don't want them coming back and saying, if you'd warned me, I wouldn't have had this problem. They can do with the information what they choose, what their doctor advises them. Of possible toxicity. In Plaquenil, as indeed in many other conditions, if you wait for diagnostic certainty, you will have done so at the expense of further damage, possibly irreversible damage, to critical tissues. And our job is to catch the disease before the patient has irreversible damage.
Every patient I have seen with this has been like a neglected, they've been overdosed, right?
Many of them have.
They've been on it for too long and too much. Have you ever seen plaquenil toxicity with an acceptable dosing
I
regimen?
just showed you one. What was it? The physician. This was 400 milligrams a day down to 200 a couple years later. Cumulative dose of 450 grams.
How often does this happen?
Pardon?
How often does this happen in the regular range?
Very rarely. I mean, they reported, less than in the AAO guideline paper.
So then we
Very
should be-
rare.
My point is, we should be screening everybody.
Their recommendation is screening at baseline, if they're continuing on the drug, resume annual screening at 5 years. That will catch practically everybody.
That doesn't satisfy rheumatology, at least in this community. They're very aggressive when they put people on there, that they want their follow-ups frequently. But apart from that, I didn't notice, can you comment at all on the value of checking color vision for these folks and body habitus as well?
There's pretty good literature that the body habitus doesn't matter, that the drug distributes equally in adipose tissue and other tissue, and the total weight is the best guideline. Color vision has been in and out of the literature, and the consensus is that it's not better than any of these other tests. And no reason not to try it, and if there's a problem that you could be sure is new, by all means, pull the plug and look at other parameters. But, yeah.
Scott, what are your thoughts about, there's always a debate, let's say intermediate dry AMD, some drusen, and then, you hear, oh yeah, you can continue the plaquenil, and it's like, no, you don't. Basically, any other medication that has another problem in that same organ is a contraindication, but not with this.
How should I say, I get these cases all the time of, people who have some other macular disorder and they're on plaquenil, and, first of all, is there synergy in the toxicity? And can I differentiate between the plaquenil toxicity and the other disease? And the answer is, I don't know, and probably not. If you're not certain that we can document that the macula is safe, the prudent thing is to go off the drug. And of course, there's a lot of disagreement among my rheumatologist colleagues as to whether there are or are not good alternatives to plaquenil. The others are certainly more expensive. They may not be as well tolerated, except for the retinas. But sooner or later, an appropriate drug can probably be found if we look hard enough.
I would Stargardt or whatever, don't take plaquenil. Right? Why would you add insult to injury?
But you've got Marmer standing up at Retina Society saying, if they got drusen, there's no reason to stop the plaquenil. It makes no sense. It's the same target and organ.
A big part of the question is, we only see the toxicity. We're looking at we're trying to protect vision. That's our job.
I've never stopped anybody with
But
macular degeneration.
the question is, if this is a life or lifestyle saving drug for a patient, then the balance is harder, the judgment's harder to make. All I can do is advise them, yes, you are at risk. Tell your rheumatologist he's welcome to call me, then we have to make a decision. We can always change our mind and stop in a year or two or whatever, but the risk will be higher.
Wait,
I don't have
you
a-
said you wouldn't stop?
I
You don't
never
stop?
have.
You never have?
No.
I don't have a crystal ball. Again,
I don't know.
we screen for a lot of toxicity, we see very little, as my little poll has demonstrated.
The 2026 guidelines for screening, it seemed like they were de-emphasizing the visual field and making the 24-2C kind of optional and saying the absolute is the OCT and the FAF. Is there a reason that you know of for that? Because it seemed like some of the cases you presented, the FAF.
Again, I've been at this for 40 years.
Yeah.
And all my life, there's been the search for the holy grail, the earliest sign of plaquenil toxicity. And I don't think there is one earliest sign. And that's why I think the screening should be multimodal. And their literature suggested that, at least the cases they looked at, that more often they saw an earlier abnormality on the OCT than they did in the field. But I would not rely on that if it were my eyes. Okay, the hour is getting late. Why don't we go ahead to my next talk?
I'm sure.
Let's see. By the way, I greatly appreciate all there for rounds on Friday afternoon.
This is actually kind of nice for us.
Okay. Now, I expect to get a lot of flack from Dr. Levin about these cases. But and to illustrate the point that I don't think we're yet at the point where we can just read the DNA and throw out our clinical acumen in trying to understand what's going on with our patients. So these are case vignettes. There's no more plot to this than this. We start with a 14-year-old boy referred for reduced acuity, slowly progressive, refracted to about 20/60, normal color vision, couple missed points on the visual fields, and my eye, which his pediatric ophthalmologist had missed, he had optic atrophy. Once you point it out, it's easy to see. As the eye slides by your quick indirect exam, maybe not so easy. One thing I'd like to point out is that a quick way to look for this and double check it is to look at a red-free photograph, either a deliberate red-free photograph or just suppress the red image in your Optos image, which the viewers can often let you do, and notice the loss of scattering from the papillomacular bundle. It's almost as good as the blue light we used to use when we had real fundus cameras. And definitely nerve fiber layer thinning on OCT scanning. And so we did a VEP and an ERG. Here's the VEP. To large checks, the responses were pretty much normal, but to finer checks, there was definitely a reduction and delay in the responses consistent with optic nerve impairment. And the full field ERG, which I won't go through in detail because your residents did such a beautiful job, are normal. Good oscillatory potentials, nice photopic responses. So we get a clinical diagnosis of optic atrophy. And we sent DNA off for testing, and sure enough, he has a pathogenic mutation in OPA1, which is the most common autosomal dominant gene for optic atrophy, so-called KERS optic atrophy, and we considered the case solved. And as I was explaining this to the father who was there with the son at the follow-up visit, he mentioned that he had a similar history. So I said, maybe we should take a look at you. It's a dominant gene. We may turn something up. And sure enough, his vision was 20/70. He had terrible color vision. He had optic atrophy clinically, nerve fiber thinning on OCT. His VEP was even worse, though his ERG was still pretty good. And he had the same mutation. Now, I illustrate this case. There's nothing mysterious or paradoxic. This is how we're all taught genetics is supposed to work. We have a family. The kid has it, they have the same disease, maybe it got a little worse over time in the father than the kid. We all go home and sleep easy. But it doesn't always work out that way. Here's a 7.5-year-old girl. She was followed for macular dystrophy for several years. Vision was about 20/50 or 20/60, and then rapidly deteriorated to about 2200, 2400. She could not even see the control plate on the Ishihara panel. Pressures were a tad high, but that's eye care, so who knows? And she had this sort of peculiar bullseye-ish sort of foveal atrophic lesion with sort of a hypofluorescent center, maybe a little bit of a hyperfluorescent ring. And I brought this case to the Ophthalmic Genetics Study Club, which Dr. Levin and I participate in, and we all found it perplexing. And so eventually, oh, by the way, here's her ERG with skin electrodes, so a little bit noisier needle, but scotopic response here, pretty decent photopic, maybe a little bit reduced photopic response. I felt that her ERG picture was one of a cone rod dystrophy. Worse cone responses than rod responses. With central atrophy, that's a reasonable diagnosis. So she came back a few years later, and the fundus picture was about the same. We're using different cameras now, so you get a broader picture of the autofluorescent defect. And we were able to do the in vitae genetic panel by now, and she had compound heterozygotic pathogenic mutations in ABCA4. So I don't know if you want to call this Stargardt disease or ABCA4 maculopathy, but that's what she had. Well, a year or so later, her brother came in, 7-year-old, pretty good vision, pretty normal looking fundus, pretty decent autofluorescence, maybe a little exaggeration of the central dark zone. Same mutations. But he's only 7, so give it time. But his ERG is very different. His rods are terrible. His cones aren't great, but they're better than the rods. So here we have a sibling pair with the same compound heterozygous mutations, but they're not presenting with the same defects. One has a rod cone dystrophy, the other has a cone rod dystrophy. I don't know why. Year later, the sister came back, but now her picture had evolved. And we now start to see bone spicule pigmentation in the nasal periphery of both eyes and a little bit more irregularity in the autofluorescence. And 4 years later, she had whopping bone spicule pigmentation. And I'm sure if I had seen her for the first time looking like this, I would have said she has retinitis pigmentosa. And her ERGs were worse, but still showed a cone rod phenotype. And by now, her brother is showing a similar, though not quite as severe pattern of pigmentary deposition. More loss of retinal tissue, more autofluorescence defect. But he still shows a rod cone phenotype. His rods are still worse than his cones. So we have 2 siblings with the same mutations, different ERG signatures, who not only had this very atypical presentation that evolved from sort of a peculiar central retinal atrophy to an RP-like picture without ever really going through the typical Stargardt's pattern of beaten bronze or a pisiform flex. Just for reference, here's a nice example of the more traditional Stargardt's presentation with the flex and the sort of both hyper and hyperfluorescent appearance in the autofluorescence like we saw in the earlier case. I don't have an explanation.
They're not twins.
I didn't say they're twins, I said they have the
I'm
same
just saying,
mutation.
they
They're not
have a
twins.
different genetic background, and therefore these mutations are playing out differently in their retinas, which are not twin genetically. So that'd be my guess, though. I don't know why, and someday we'll figure out what those secondary mutation and polymorphisms are that cause this.
Yeah.
But ABCA4, we see this kind of phenotypic variability.
I mean, it's worth emphasizing in general that ABCA4 is a huge gene. I don't know, 27, 30 odd exomes or something like that. And the spectrum of disease associated with it seems to grow every year. We see more and more different kinds of presentations. As I said, I showed everything from RP to foveal atrophy, all kinds of things. So never rule out ABCA4. Here's another one. A 57-year-old woman, 4 years of painless progressive visual decline in the right eye. The left eye sees 20/20, the right eye is 20/50. She has an APD. In the right eye, normal color vision in the left eye. That's odd. Normal anterior segments. The visual fields, the left eye is fine. The right eye has this sort of rather large scotoma emanating from the disc, maybe a little bit more than that even. She was actually sent to me by a glaucoma doctor who thought this field was peculiar. Here are the color photographs. The discs are a little big. That's why she got to the glaucoma guy. But the front eye looked pretty much normal. Here we go. The autofluorescence is pretty benign. The OCTs are subtle. Here in the right eye, the one with the defect, there's a sort of subtle breakdown of the ellipsoid line and outer retinal structure just in the foveal region in this eye, and the other eye looks perfectly normal. The multifocal ERGs are, wow, you know, the left eye is all but extinguished. And the full field ERGs are almost as bad. The light adaptive responses and the dark adaptive responses from the left eye are fine. In the right eye, the photopic responses are very poor. The dark adaptive responses, the rod responses are better. Not quite as good as the left eye, but better. So she underwent a very extensive workup looking for some kind of localized inflammatory disease that might explain the asymmetric damage to the retinas, but got us absolutely nowhere. No history of trauma, no family history, no inflammation. And so she went for genetic testing, and we found single heterozygous variants of uncertain significance in 3 genes. Our best guess is that she's exhibiting an effect of the PRPH2 gene, which is autosomal dominant. But I don't know why it is affecting. And here it's even more perplexing in the sense that no matter what explanation we give, either we've explained what's going on in the healthy eye, or we've explained what's going on in the diseased eye, but not both simultaneously. Now, this is not an X-linked gene. This is not coarse lionization. Perhaps it's some kind of somatic mosaicism of some additional gene, but it is very perplexing. This is another young woman. She presented with this little patch of bone spicular pigmentation, sent to me as a rule-out retinitis pigmentosa. Other eye looked swell. On autofluorescence, the sector was quite dramatic in its hypofluorescence. You could see a little bit of loss of the outer retinal structures in that region. The other eye looked fine. Goldman fields, we had a nice. You have a very localized scotoma that corresponds pretty much exactly to the location of the pigmentation. She is the daughter and granddaughter of patients who were previously diagnosed with classic retinitis pigmentosa, and she and her father have confirmed mutations, the same mutation in the rhodopsin gene, which is an autosomal dominant gene for RP. So it's the same. In this case, we have sort of almost a more intensive paradox as in the previous patient. Why only one eye? And in the one eye, why only in one little sector? I guess you could say she's mosaic for something, but I have no idea what, and I don't know, short of a multifocal retinal biopsy, how we're ever going to find out.
Dr. Schwartz here might find out. She's starting a project where we're going to be doing conjunctival biopsy in patients with monocular disease as a process of the eye, and it's not neuroectoderm, to see, in particular for anterior segment dysgenesis, whether we can look for somatic changes in an eye, working with Wisconsin to isolate DNA and sequence that.
Yeah, I mean, it's known in retinal-blastoma.
It's known in Coates disease as well. We've shown that. So it happens.
Okay, we've got, I think, one more here. 47-year-old man, 2300 vision, very sparse bone spicular pigmentation. You really have to stretch to see it. Some autofluorescence irregularity, but not too severe. The OCT looks worse with peripheral breakdown of the outer retinal layers. His ERG is terrible. The scotopic responses are very poor. The photopic responses are not much better. And he has a heterozygous pathogenic mutation in PRPH2. It's a gene we've seen before. It's an autosomal dominant gene for RP. Fair enough. The only problem is he has 20/20 or 20/15 vision, perfectly normal retinas, perfectly normal ERG, and the same mutation. So I don't know why the same mutation causes significant retinal disease in one brother and none whatsoever in the other.
Why was the brother tested?
Pardon?
Why did the brother undergo testing?
Because his brother had the disease and he said, I have a brother, and we invited him to come in. We wanted to see what was going on. It was just gracious of him and just our curiosity. He was perfectly asymptomatic. So this is my last slide, I think. No, not quite. So this comes down to a question of nosology. What defines a disease? We are now 31 years, practically to the day, from the publication of the first description of a retinal disease gene, which was the rhodopsin mutation in retinitis pigmentosa. And at that point, a lot of people said, gee, this is going to be the first of many, and we can throw cameras and can throw away our ERG machines, and we'll just do a buccal swab, we'll read the DNA, and we'll know what everybody has. And here we are 30 years later, and it has not worked out that way. There are many ways to define a disease entity. They are not necessarily in parallel. Everything from symptoms to physical findings, laboratory tests, imaging, and genetics. So the moral of the story is, don't throw out your ERG machine. Thank you very much.
Any questions for our guest? All right, I would like to present you, Scott, with this plaque to commemorate your visit, and thank you for coming and educating us as well as educating our staff, which is very, very important. Thank you so much for coming and sharing your time with us.
My pleasure.